So our next speaker and our last speaker before the lunchtime break is Dr. Dara Kraitchman, who's a professor of radiology and molecular and comparative pathobiology at Johns Hopkins University School of Medicine. Dara founded the Center for Image-Guided Animal Therapy at Johns Hopkins. She has spent extensive time understanding the ethical considerations of performing veterinary clinical trials in interventional radiology and cardiology, and has lectured for numerous societies on these topics. And some of those societies include Priminar, Public Responsibility in Medicine and Research, and the American Heart Association. Dara is here to talk to us this morning about image-guided animal therapy. So welcome, Dara.
Thank you. Can you hear me okay?
Yes, I hear you.
Great. So I want to give a sort of shout out to the people at CAAT, USDA, OLAW, and especially our attending veterinarian at Johns Hopkins, Eric Hutchinson. He really, I don't really think of myself as doing refinement, but he sort of pointed that out to me. I really just sort of do what I love, and I'm really happy that I can talk a little bit about this center that we've created at Johns Hopkins. So I do have a few financial disclosures that I'm required to disclose. And I think being from Johns Hopkins, I guess we have sort of this One Health idea that goes back quite a long ways. And in the molecular and comparative pathobiology, we have a picture of the dog Anna that Vivian Thomas actually used to develop the Blue Heart operation for treating tetralogy of Fallot, which is a combination of these various heart defects that happens in children. And Anna was, although she was a research dog and did not have tetralogy of Fallot, she was instrumental in actually being able to develop this operation for kids. And we've celebrated, I think, more than like the 50th anniversary of some of the children that have been treated now. And we, as you know, and sort of, I really thank Amy LeBlanc for being the starter of this session, because she sort of provided some of the foundation. We didn't share slides. Unfortunately, I've decided not to talk about osteosarcoma in my talk, so she's covered it quite well. But we do know that there's a lot of heart disease in our patients, and in this case where I'm showing a small bulldog that has pulmonary stenosis, which is well known to occur in this breed. So my background actually was very traditional. I did a combined degree program, getting my veterinary degree at Penn and doing my PhD in bioengineering, mostly with human physicians. But we were creating animal models of disease. In this case, it's myocardial infarction or a heart attack in a dog. And these are images taken with cardiac magnetic resonance imaging. And so this is the left ventricle and the right ventricle, and we can see the beating heart. And that this is a way to look at perfusion in the heart as well as function in the heart. And finally, we see this sort of hyper-enhancing area, which is late gadolinium enhancement. That's a sign of the myocardial infarction. And quite honestly, in our dogs, we don't have a lot of ischemic heart disease. So I learned a lot of things from my human colleagues of how to do cardiac catheterization and minimally invasive techniques, that I was creating these models in normal purpose-bred dogs. From that, I moved to Hopkins and continued doing a lot of the same things. We moved to pigs in this case, and we were doing labeling of stem cells so that we could see them non-invasively in the heart. And so these are iron-labeled stem cells that we've placed in an area of, again, this myocardial infarction. In this case, it's a pig model. And I think sort of my aha, you know, I had always wanted to be able to translate some of this back to our pets, but as I said, we don't have a lot of infarction or ischemic heart disease in our dogs and cats particularly, so I didn't see a lot of opportunity to do that. But I was actually attending a conference at the University of Maryland. Well, it was held, it was work done by the University of Maryland, but it was actually a cardiac retreat from Hopkins. And they had looked at the Amish Americans, which are a very closed genetic pool, mostly of Eastern European descent, you know, similar in some ways, and they were able to use this population to actually look at a drug that was being used after cardiac cath and placing stents that seemed in certain patients not to work well. It was discovered, clopidogrel, that this anticoagulant drug, and certain people had certain genetic changes that was found just using this very close population of Amish Americans in the Pennsylvania Dutch area. that they had this genetic mutation that made them non-responsive to this. So they were not, so you could easily test patients and decide whether to put them on this anticoagulant or another one. And so this sort of led me to the idea that, you know, we have our dogs, especially our purebred dogs, is a really closed genetic pool, very few founders. As Dr. LeBlanc said, many of our owners are seeking advanced treatment for our pets. They share the common environment. So it seemed like this would be a good way to actually pursue some of the things that we wanted to do in imaging. And I think there's been some other talks during the week during the past 3 days that sort of talked about sort of the traditional models where you develop things. And usually murine species, you have this advantage of these transgenic and knockout mice. And then if you see something promising, sending it to human trials, which start at phase 1, a few patients. And many of these trials fail, and it's very expensive in these early phases. So the idea of actually using animals that have spontaneous disease, and in this case, pets, is very attractive for doing a variety of things. But I'll sort of go back to the imaging standpoint. For imaging, we use different systems when we get to very small rats and mice. And so we can use actually clinical grade or human imaging systems with our pets, which is very attractive, as well as with their larger size. If we're developing devices, then a lot of them are not amenable to these smaller murine species. So with that in mind, in 2012, I convinced the higher ups at Hopkins that we would establish the Center for Image-Guided Animal Therapy, which is a Maryland licensed veterinary hospital within our Johns Hopkins Human Hospital. The idea was to use existing animal facilities to perform diagnostic imaging in veterinary patients, in other words, our pets. And part of this was brought by the building of our new hospital in the Zaya Tower, which I knew was going to enable us to have extra imaging capabilities. So in this center, our bread and butter, and I this morning had to come into work because we frequently have emergency cases, which after I finish this talk, I will be doing emergency case. So mostly our cases are cats and dogs, but we do get occasionally the exotic species, whether they be birds or ferrets or things from the zoo or aquarium. And we perform this general routine imaging, but we have the advantage that we have the latest imaging equipment and also some of the newest things that are coming along with our collaboration with the imaging equipment vendors. Most of our caseload is MRI, with a smaller percentage of it being computed tomography. And as I said, we're a licensed hospital. All of our clinical trials that we do are approved by our Institutional Animal Care and Use Committee. There is the advantage, and this is very US-centric based, but in general, there's no investigative new device requirements for pets in the US, so we don't have to get what we call an IDE for most of the devices that we would want to test in pets. And also, if we're testing a drug that we don't really intend to give to veterinary patients in the long term, we don't actually need this investigational new animal drug or an IND in the equivalent on the human side. And for some of our biologics, again, we don't need USDA approval for those. So that's an aid of sort of a regulatory standpoint of being able to do clinical trials at a lower cost. So in addition to that, one of my goals was actually to translate some of the interventional procedures that I was developing in purpose-bred animals and taking it to people, and then actually getting it back to advance the therapies for our pets. So I'm going to show you just a real quick example. This is a relatively not uncommon disease in people where they have lymphatic venous malformations in their peripheral area. In pets, we primarily see it in the abdomen, but this was a 4-month-old golden doodle that had a lump. The surgeon went in to take it out, realized right away that they didn't know what they were into. And we quickly looked at this with ultrasound and realized it was one of these LVMs. And so we were able to take a treatment that we commonly have developed for people, which is injecting an antibiotic under ultrasound guidance. So you see these little bubbles that we inject with the agent into this area, and it causes it to sclerose or close down. It's a very minimally invasive technique. And so this could be done in a relatively young pet. In addition to actually translating these interventional procedures back to pets, we realized that this could also be a platform for developing new devices, imaging techniques, and as well as looking at drug therapies. So I didn't know that Dr. LeBlanc was going to show these slides, but my real point here is that when I think about pets and people, especially for developing imaging devices, I'm thinking about things that actually would have to be amenable to not only adult patients, but also pediatric patients. So even our largest dogs, Irish Wolfhounds, are really not the size in general of what we're seeing for our human patients. So we have to think about how we're going to size these devices for pediatric patients, which sometimes can be challenging. So how do we choose the clinical trials that we're going to do at Johns Hopkins? And I kind of look at it as the Shark Tank of, and divide it into two major buckets. So we can have a company that comes to us that has some agent that they're very interested in testing, and they realize that we have either the imaging equipment or the patient profile that they would like to actually test their drug or device. So I call it sort of a CRO or contract research organization driven type of project. And then the other one is academic driven. So these are ideas that we're really interested in, and we maybe approach the company themselves, or we have been working with a company and we actually want to expand this to our veterinary population as well as our human population, or we go out sort of the more traditional route and do grant applications for foundation and government sponsored research. And in our experience, and it's short now, we've only really been doing clinical trials 5 years, the bucket 2 has actually been much more rewarding than the bucket 1 because we have a lot more input into it. So I'm going to give you just a couple examples in my sort of remaining time of things that we have been working on. And one of them is this yttrium-90, Y-90, which is used for trans-arterial radial embolization. So that's quite a mouthful. But these are basically small little beads, 20 to 30 microns, that have a radio label that's a beta radiation label on them that's used in people with liver cancer. So a minimally invasive technique where they feed a catheter from the groin into the liver and then inject this Y-90 bead into the tumors in the liver for hepatocellular carcinoma. The advantage of this is that you get a very high concentration of radiation in that small area, and the radiation only travels a small distance. So it's sort of like doing external beam radiation therapy, but locally. And so the advantage of this, unlike the chemo embolization, which was originally developed for hepatocellular carcinoma, is this often can be curative. So we were sitting here thinking, well, Y-90 works in the liver. Why couldn't we use it for other applications? And one of the applications that came to mind was, could we use it for brain tumors? One of the major brain tumors is glioblastoma multiforme, GBM, and it typically reoccurs at surgical margins. So when you're taking a part of the brain and surgically resecting it, you're very conservative about how much tissue you're going to take, and the tumor tends to expand from that area. So we realized that in the areas where the tumor is resected on the margins, it tends to be very hypervascular. So it has a very good blood supply. And so potentially if we could get these beads to that hypervascular area, we could get the unresectable infiltrating tumors. And one of my colleagues, knowing that I'd worked in pigs, said, hey, could we do a pig model of brain tumors to actually test this out? And I said to him, well, why would we consider doing pigs, that don't have naturally occurring tumors? Why wouldn't we look at dogs? Meningiomas are our most common brain tumor in dogs. They tend to occur in dogs with long snouts like golden retrievers, whereas these GBMs are our second most common tumor. They tend to occur in push-nosed dogs like boxers and Boston Terriers and French bulldogs. Our standard of care in veterinary medicine is, if possible, we will surgically debulk and then not usually follow with chemotherapy, which is a standard of care in people, and then usually radiation therapy. But regardless, whether you're looking at people or pets, the treatment options are poor. And I have to say, when I talk about the Shark Tank and people coming to me with treatments, especially drug treatments, they'll say, look, these dogs have GBM. They're not going to survive very long. Why don't we try this? It's worked really well in mice or rats. And that's kind of, it's a little bit scary to just immediately jump to someone's pet, because even though the pet has a very bad disease, I don't want to be the one that actually hastens that death because there can be some problem associated with that. So when we thought about doing this trial, let me see if I can go back. I seem to have jumped several slides. That's just a picture, and you can see that a large portion of the brain is actually contains GBM in this dog. It's not you could not surgically resect this much brain. And the key here is the mean survival time of this dog with optimal medical therapy, so no surgery, would probably be 63 days. So while it is a short lifespan, I do want to be very safe in what I do, because I don't want to hasten the death of this dog that could enjoy a relatively good couple of months, and I can't predict which ones are going to survive longer or less long. So as I mentioned, Y-90 has a 3-day half-life. It's a beta emitter. So we had to ask ourselves a lot of questions if we were going to actually do this in people's pets, is that once we give this, and it'll be mostly in the skull, would it be safe for the pets actually to return home, or would we actually have to put them somewhere so that we wouldn't be irradiating the pets and their children and other people in the environment? The other thing we asked ourselves was, well, neuroangiography in pets, well, I've done a lot of cardiac catheterization and other peripheral vascular techniques, is not commonly done in pets. How do we best approach that? You know, what devices are we going to use for that? And so something that's sort of not talked about using pets as models for disease is that, and that we often use even in just not spontaneous disease, is developing how are we going to actually do this workflow so we can do it efficiently in a patient that might be under sedation or anesthesia. So we had 3 major areas we had to think about how we were actually going to do dosimetry of this Y-90. So we'd have to do a preoperative or pre-treatment MRI. Follow that, how are we actually physically going to do the angiography, what devices are we going to use, how are we going to treat the animal afterwards. We want to look at how our delivery was, so we'd follow the angiography for the PET CT, so that's a relatively long session that we'd actually be treating the animal, and then follow up adverse events, the radioactivity levels to protect the patient. So we had a lot of things that we needed to work out as far as workflow. So this was done in combination with the vendor that makes Y-90, in this case the glass bead, which was BTG. And so their idea was originally, well, we'll let you do 1 purpose-bred dog to get this workflow down. And that's what they agreed to. And we said, okay, we'll do 1 dog. And knowing full well that if we didn't feel safe with 1 dog, we weren't going to proceed. But we said, okay, this is how we're going to do it. And so we would get a pre-treatment MRI and a dog that was normal, a purpose-bred dog, and then follow it by our Y-90 treatment, which would be done in this specialized close suite. That would be done on a different day. It didn't have to be simultaneously on the same day. And then we would follow that by our PET CT. So you can see we're moving through various different imaging equipment. So that involves like moving and using different teams of people. And then we would do steroids and neuro exams and follow up and see what the effect of this treatment was, because now we were giving a therapy in a closed space, unlike the liver. So we worry about the brain swelling and causing more harm than good. And then follow this with a follow-up MRI to see if there were any adverse effects, as well as actually euthanizing this purpose-bred dog and looking at the brains and seeing if there was anything that we were concerned about. And so this initial 1 purpose-bred dog ended up being 3 dogs, some of which we actually found out things that we weren't doing right, and we weren't able to do the delivery and followed that again. So this stage is, I find, crucial. And although we're using, our goal is to do spontaneous disease in dogs or naturally occurring disease in dogs, seldom can you skip this step. Even if you have someone who comes to you with a drug, typically if they maybe have this drug that they're using for a human purpose and then they want to actually try it for another indication, they may have some safety data already, hopefully in dogs or whatever species it is you're hoping to do that has a spontaneous disease. So we did that, and through that we developed as you can see, this is several pages, and this is just the day of the angiography of the preparation that goes in and all the different steps that were going to occur. So it's sort of like that timeline that Dr. LeBlanc showed you a follow-up, but this is just a single day. And this actually is critical, that when we're going to bring in a patient for a procedure that's never been done in a pet dog or a pet cat or any other pet, that we make sure that we have all these things that we're going to do as far as a procedure are dotted and crossed. And not to say that in the clinical trials that Dr. LeBlanc was doing, but when we're doing imaging procedures, we sort of need to think about all these steps that we need to take. And so through that, we were able to feel safe that we could then move to dogs that had what we call hypervascular tumors, because we weren't going to chain a biopsy. And we completed what we considered our full phase 2 in dogs, but it would be like the equivalent of a phase 1 trial in people, where we basically did a safety study with a bit of looking at efficacy. And as you can see, these are the 5 dogs that we treated. We're nice that we can actually, we name our dogs. We don't have to give them numbers because we don't have HIPAA violations. And 3 of these 5 dogs are still with us today. So when you consider that it's a 63-day survival time, and the dates in the hearts are actually the date that we treated those dogs, which sometimes was several months after they were first diagnosed, it seems to be a fairly good prognosis. And so from that, the company has gone back and they're going to consider where they want to use this data to move with the FDA to people. But we're fairly confident that we at least have a life extending potentially procedure and we're comfortable enough with it that we're willing to actually offer this to canine patients as a treatment right now. With that, I'm going to quickly move to just another example. And this was, I had heard within our institution that they were developing a low-cost cryotherapy device. So cryotherapy is a way to freeze tumors. And this device was originally developed to treat cervical tumors that weren't necessarily malignant. And the idea was to use this to treat breast cancer in third world countries. And using the system, they used what we call low-cost cryogen, or CO2, the same thing that you have in your soda or soda pop. And that's available widely in limited resource countries. And the idea was they were going to make this, all their disposables cost about $1. So this would be very affordable for a third world country. And I saw this and realized, could we actually repurpose this for the veterinary market was really my question, because within our institution, we have what is considered a commercial cryoablation device that actually does the same sort of concept of freezing tumors, has these relatively long needles, but it uses very expensive gas like argon and helium. It is used right now for palliative treatment for bone tumors and metastatic disease, as well as a primary treatment in people for renal, adrenal, liver, and prostate masses. By using freezing and thawing of the tissue, you cause not only cell death, necrosis, but programmed cell death or apoptosis. And it's usually performed under some image guidance. But these systems cost in excess, $100,000 is probably low, more about $250,000 by the time you install them. And so this is not accessible to the veterinary market, but we could use something like this to treat veterinary patients. So I approached this sort of startup that was developed through a senior project at Johns Hopkins and said, hey, would you be interested in developing this for veterinary patients? And so we already had some experience of using our expensive cryoablation treatment to develop this to treat metastatic disease in the spine. So this was actually a pig study. So this is an immature pig where we were actually placing these needles in the spine and then freezing them. And so under MRI, which are shown here, you see the ice ball appears as a negative void. So I had experience with actually doing cryotherapy in research animals. We've taken that same procedure and we've translated it to treating bone tumors and actually taking bone biopsies in the spine in pets. And so I felt fairly comfortable. Here's an example of actually a pet that we're treating that has one of these, not actually a tumor, but it's called an aneurysmal bone cyst. So it's a sort of bloody, sort of benign tumor, and showing the freezing. And so when we do this under real-time guidance, you can actually see this ice ball growing, expanding, and that during the freeze cycle, and then during the thaw cycle, it'll retract again. And so since the spinal cord is here, we have major vessels like vena cava and aorta that are really critical to life itself. It's really important that you be able to monitor something in the spine under MRI. But for other tumors, potentially one could do it under ultrasound or CT. So what had been done with this low-cost device is they sort of had developed a more standard route where they had taken Sprague Dawley rats and they had implanted them with tumors and then used their device to freeze these subcutaneous tumors and then looked at that therapy. So they had some efficacy data, and then they had approached us about actually looking at something that was more internal that would have a large heat load, and we said, why don't we look at freezing just normal pigs? So this is, again, not a spontaneous disease or any pig that has liver tumor model, but we just use this to actually do sort of more basic preclinical research and showed with histology that we had freezing that was comparable to what we expected from the device. So we sort of had demonstrated the efficacy of that device. And so already knowing how to use cryotherapy, I felt relatively comfortable to then take this into a sort of phase 1 trial in pets. And we decided to do something very, not very dangerous. And instead of going in to look at treating deep tumors, we decided to do just lumps and bumps in pets and offered free removal. And we have many ways that we try to recruit patients. This is not a patient population that we normally see for imaging. And so the word free seems to be very popular. And so we put these flyers around, and with about 24 to 48 hours, we had 250 responses to our clinical trial. So we were quite overwhelmed. This is us doing, and initially we had thought, well, we'll do the cryotherapy out at veterinary clinics, and since we're using their patients, but we decided since we really had the expertise in cryotherapy, the cryotherapy was done in-house, but then the surgical resection was done at the veterinary patients. And so we've now completed a short phase trial that was sponsored by our Maryland Technology Development Corporation. And now we've received some more money to actually sort of roll this back into a phase 2 trial, which will actually be starting to teach veterinarians how to use this device, look at case selection of who's the best to treat, determine things like client patient satisfaction, and ultimately this company will develop a marketing strategy based on that. So very successful in a small amount of animals, moving this to hopefully a veterinary product. I think in the interest of time, although my area is heart failure, I'm going to kind of skip over this, but it is important. We think about cancers in pets, but about 1 in 10 dogs over 5 years of age will have heart disease. So it's a very big problem, actually, and 3 to 4 in 10 dogs over 12 years of age will have heart disease. So we sort of don't think a lot about cardiac disease in our pets. It's very difficult for some of our things we want to do because our pets are so small to do interventional techniques, and we don't have things like coronary artery bypass in many places, so that surgery is very difficult. We do have some dogs that have these genetic chain tests that we can test for that have a high incidence of developing, as I said, not ischemic but non-ischemic dilated cardiomyopathy, as well as we now have dilated cardiomyopathy that's been associated with grain-free foods. So our group has been very interested in then taking some of the techniques we use and using this as a sort of not any interventional techniques, but just using straight imaging techniques to develop abilities to look at subclinical heart disease in our pets that have these genetic defects, and then possibly look at agents that we could give these pets to look as sort of looking at early stages before they have the disease to be preventative. I'll quickly, this is my last area. We also know that obesity, which is something that often isn't talked about, is in our pets because it sort of has a reflection often in the owners, but obesity is a epidemic just like it is in people. And as much as I would like to try to do some of the techniques in pets, and one of the things we've developed is a way to take some of these small spheres that are not radioactive and inject them into patients. I go back to what Dr. Nadesan Horowitz said in her first talk about this is really sort of somewhat of a lifestyle disease. And so I have a trouble actually doing a medical therapy in people's pets that might be obese when we really should maybe be modifying their lifestyle. So in summary, I just want to say that there's a lot of ability to not do refinement and reduction number of animals, but we often need to do this sort of initial purpose-bred animals for safety and workflow and feasibility. One of our big hurdles, we are not a vet school, and so we are an academic medical site. So how do we actually get our animals into our state-of-the-art equipment and also recruitment? And really, we're taking advantage that we're a major metropolitan area of recruiting vet patients from our surrounding specialty and general practices. And we can often use our pre-existing knowledge so that we can sort of shorten the number of animals that we need to actually use, so we can reduce animals in the timeline to actually have proof of principle. And often we can, as we're developing this in spontaneous disease in pets, we can then move it quickly back to the actual veterinary patient. I just wanted to add this sort of COVID-19 addendum, which is sort of interesting to say. So in most states, veterinarians were considered essential, with veterinary care continuing through most of the stay-at-home type of orders. And so although in the interest of best judgment for preserving PPE, we did suspend enrollment of patients in our veterinary clinical trials. We anticipate that we could actually resume clinical trials more rapidly because there's no need to order animals and wait for them to arrive and all use personnel that have to actually house those animals. So with that, I'd just like to acknowledge there's a huge number of people who've actually helped me with my interventional radiology, cardiology, and neuroradiology training, as well as participate and provide scientific and physician and veterinary assistance, as well as our funding agencies. And then I think we have time for a panel and a few questions.